Welcome to Vital Signs. Some of this may be a review for you, and for some of this might be brand new. So what are the vital signs? Well, vital signs are our body's way of telling us we're alive. They are the physiologic functioning of our bodies, and they reflect our health status. The vital signs are temperature, pulse, respiration, blood pressure, pulse oximetry, and pain is also often considered a vital sign. We will have a whole lecture dedicated to pain at another time, so pain is not going to be addressed in this PowerPoint. We use vital signs to tell us how stable or unstable our patient is, if they're getting better or getting worse, and how alive they are. When we relay vital signs to other healthcare providers, it's often spoken in a TPR-BP fashion, meaning I say my temperature first, then pulse, then respiratory rate, then blood pressure, and then pulse ox last. So when do we assess vital signs? All the time. But there are some times that truly dictate vital signs being done. The first being upon admission to your healthcare facility. We need a set of vital signs as soon as they come in so we know what their vital signs look at that moment in time. We call these our baseline vital signs, and we'll use these to know how the patient is doing right then, and then we'll use them to gauge if our patient is getting better or worse. We must also do vital signs based on our facility's policies and procedures. If our policy says we do vital signs every 4 hours, then that is the minimum amount of time we must do them. Knowing that these policies change depending on the level of care of the patient. In PACU or the recovery room, we do vital signs every 5 minutes. We also do vital signs anytime there's a change in patient condition. If they look different or sound different or they're acting different than they did even 5 minutes earlier, we need to do vital signs. Something has changed and we need to figure out what. This also includes any loss of consciousness. We need to do vital signs before and after any surgical or invasive diagnostic procedure. This gives us a baseline set of vital signs and allows us to monitor the patient to see if they're recovering well from the procedure or not. We need to do vital signs before and after any activity that may increase the risk of harm or injury to the patient, which might be as simple as ambulation. Each person's risk is going to be different, so not everyone who ambulates is going to need vital signs. And then we also need to assess vital signs before we give any medications that may affect cardiovascular and or respiratory function. We need to know what their vital signs look like before we give the medication and again afterwards to make sure nothing is drastically changing. And of course, we can assess vital signs anytime we think something might be changing. Each vital sign in our body has its own normal range. And their range is for a reason, because every patient is different and everyone can have different vital signs. The range helps give us an idea if they're stable or not. In block 1, we only discuss adults, so we are going to discuss the normal ranges for adults. For temperature, our normal range is 96.6 to 99.5 degrees Fahrenheit, or 35.9 to 37.5 degrees Celsius. Yes, it is normal for people to have a temperature less than 98.6. 98.6 is just an average. The normal pulse for an adult is 60 to 100 beats per minute. The normal respirations for healthy adults are 12 to 20 breaths per minute, and the normal blood pressure for an adult is less than 120 over less than 180. And the blood pressure standards are set by the American Heart Association. When it comes to what things can affect vital signs, basically everything can affect one or all of them. The time of day can affect vital signs. For example, if it's nighttime and the person is asleep, we expect to see the vital signs slow down and decrease. But if it's daytime and they're doing a lot of physical activity or even exercising, we expect them to all speed up and increase. The patient's age and biological gender affect vital signs, which is why we have ranges for infants, children, and adults. Hormonal differences between the genders can affect vital signs, especially temperature changes in women during their fertile time frames, as well as the person's state of health. Sick people have changes in their vital signs. Pain and stress or high emotions will alter your vital signs, sometimes drastically. Environmental temperatures can affect vital signs, with cold temperatures more likely to slow and decrease everything, and high temperatures more likely to speed up and increase vital signs. Medications, especially those that function to alter vital signs, will affect vital signs, and some have side effects that can affect vital signs. And then we have food and liquid consumption. Food typically signals our body to rest and digest, so things can slow down or decrease after we eat. Caffeine and alcohol are known stimulants, so consuming these are going to speed up and increase our vital signs. Alcohol will eventually start to slow things down and decrease them, and in some people, alcohol doesn't speed them up at all, and they just slow down and decrease and go right to sleep. All right, now we're going to start focusing on each vital sign itself, and we're going to start with temperature. We've already mentioned that the normal temperature is 96.6 to 99.5 degrees Fahrenheit, or 35.9 to 37.5 degrees Celsius, but depending on where in the body we assess the temperature has its own normal values. The 36.6 to 99.5 Fahrenheit, or 35.9 to 37.5 Celsius, is the normal range for oral temperatures, so in the mouth. If we take a rectal temperature, we expect that the normal temperature, to be higher because we're assessing their temperature inside their body. We call this a core temperature. Rectal temperatures should be about 36.3 to 38.1 Celsius, or 97.4 to 100.5 degrees Fahrenheit, so slightly normal than oral. Axillary temperatures, which are skin temperatures really in our armpit, tend to run a smidge lower than oral temperatures at 35.4 to 36.9 Celsius, or 95.6 to 98.5 Fahrenheit. Tympanic temperatures, which are in the ear, not technically a core temperature, but it is kind of inside the body, so it does make them run a little warmer than oral at about 36.8 to 38.3, or 98.2 to 100.9 Fahrenheit. Temporal artery temperatures, which are the most frequently used temperatures now, are actually using the temperature of the blood in a temporal artery, and if done correctly, are pretty darn close to being core temperature readings. Sadly, pretty much no one does them accurately most of the time. Temporal arteries readings range from about 36.3 to 38.1 Celsius, or 97.4 to 100.5 Fahrenheit. The reason that we say both Celsius and Fahrenheit is because in America we live in a metric healthcare system with an imperial normal people system. So a lot of people will talk in both. All the documentation I've ever done and ever seen in my career has always been in the metric system, meaning we're going to use Celsius. Now let's look at the things that can affect our temperature. And to affect our temperature, we really need to look at the physiology of temperature regulation. The hypothalamus in the brain receives messages from the body about the temperatures and initiates responses to either produce body heat or increase heat loss. It does this all day long without us knowing most of the time. If our hypothalamus senses we are cold and it says we need to produce heat, then our body starts to produce it by using our metabolism. We might start moving around, using our muscle movements and physical activity to increase our metabolism to produce heat. The hypothalamus might trigger our muscles to start tremoring, which is shivering. Shivering is muscle movement, and that produces heat. Our skin muscles contract and create goosebumps that reduce the skin surface area to stop heat loss from the skin. If our hypothalamus says we're too warm, the body will send more blood to the skin surface, allowing heat to dissipate. We're going to start sweating, and sweat evaporates, and when it evaporates, that cools down our skin and body temperature. So now we know how the temperature is regulated in our body. Let's look at what affects these. The first thing is called circadian rhythm. That is our body's natural ebbs and flows during the day and during night. So different days or different times of the day is going to affect our temperatures, just like our hormones are going to affect our body's temperature. We can have changes in our body temperature by as much as 1 degree Fahrenheit just based on the time of day and our circadian rhythm. We tend to be the coldest while we sleep and the hottest in the late afternoon. Our biological gender affects our temperatures based on our hormone levels and the amount of adipose or fat tissue versus the amount of muscle mass we have. Men tend to have more muscle, females tend to have more fat. Hormones like estrogen also affect our temperatures, especially when women are in their fertile periods. Temperatures usually increase during fertility. Age affects our temperatures because the very young and the very old don't have perfect thermoregulator responses, so they may not react or change the same way that normal adults do. And that's why you see a lot of older people wearing jackets when it's summertime, and that's why we have to keep babies all bundled up and nice and warm. Physical activity warms us up because our muscles are moving around and generating heat. Oppositely, not moving around, like sleeping, doesn't produce heat, so we tend to be cooler when we aren't moving. Our state of health can dictate our temperature. If we're sick, we tend to produce a fever or a high body temperature, and if we're not sick, we usually have a normal body temperature. And of course, our body does respond to the environment around us. If we're outside in Phoenix in July when it's 120 degrees, our body temperature will rise and we'll start to sweat. If we're outside in the snow in January, we're going to get cold and we're going to start to shiver and get goosebumps. The most common alteration in temperature is a fever. A fever means having a body temperature above normal or hyperthermia. Medical term-wise, a fever is called pyrexia. We would say the patient is suffering from pyrexia. We have several other terms that we can use when we have a person with an elevated temperature. Of course, everyone knows the term fever because it's a very common word out there, but we also have febrile. Fever is more of a noun and febrile is more of an adjective. We would say the person has a fever or the patient is febrile. We could also say the person is hyperthermic. If the person doesn't have a fever, we would say that they are afebrile, meaning they do not have a fever, or we could say they're normothermic. If someone has a fever, but it goes down to normal on its own at least once every 24 hours and then goes back up, we call that an intermittent fever. If somebody has a fever that never goes back down to normal, but fluctuates a few degrees, we call this a remittent fever. If someone has a fever that doesn't vary much and stays pretty much the same high temperature all the time, we call this a sustained or continuous fever. If someone has a fever and it goes away for a day or two and then comes back, we call this a relapsing or a recurrent fever. We don't talk about low temperatures very much because it usually only occurs with exposure to cold environment. But if somebody has a low body temperature, we call this hypothermia. And being hypothermic is not a good thing, and it usually has a poor outcome. Now let's move on to pulse. Our pulse is our heartbeat rate, how many times per minute the heart is beating or contracting. Our pulse, or heart rate, is regulated by our autonomic nervous system through the SA node in our heart. This will be very important in Block 2 when you start learning about cardiac rhythms. Our autonomic nervous system, just as a refresher, is our sympathetic and parasympathetic response to stimuli. Our parasympathetic nervous system is our rest and digest. Parasympathetic slows everything down, just like our heart rate. When we're relaxing, digesting our lunch, our body slows down. Our sympathetic nervous system is our fight or flight. We're going to fight that bear that's attacking us, or we're going to run away as fast as we can. Sympathetic speeds everything up, including our heart rate. When we feel for a pulse, we feel over a peripheral artery, or we'll actually listen to our heart. When we assess a pulse, we're actually doing more than just counting. Of course, we count, and if the number is below 60, they are bradycardic or have bradycardia. If they have a heart rate between 60 and 100, they have a normal heart rate or normocardia, but no one uses that term. If their heart rate is above 100, they are tachycardic or they have tachycardia. We also assess the amplitude of their pulse. Is it bounding, like it's beating really, really hard, or is it thready and really hard to feel? What is the quality? Is it strong and easily felt, or is it weak and hard to feel? And then we check the rhythm. Is it coming exactly on beat every single time like a metronome playing, or is it irregular, coming whenever it feels like it? There are many places to assess a heart rate. The easiest and most commonly used is the radial pulse. That's the pulse you feel on the thumb side of your wrist. In the bend of your elbow, we have the brachial pulse, which is sometimes hard to feel well enough to count. We can use the carotid artery to count, but if we do that, we're limiting blood flow to the brain, which is bad. So we really only use that spot to count pulses if we think they may be dead or dying, and think back to BLS. You can also use the temporal artery, but it's a very small artery and it's hard to feel consistently. The femoral pulse in the groin is big and strong and easy to count, but most people don't want to lower their pants to show us their groin so we can count their pulses. So we tend to use that spot in emergency situations when we think they're dead or dying. And moving down to the legs, we have a popliteal pulse behind the knee, which is hard to find in many people, so it's not a great one to use to count pulses. And lastly, we have pulses in the feet. We have the dorsalis pedis and the posterior tibialis, and both of those are not great pulses for counting. When we assess how strong pulses are, or the amplitude, we use grades to discuss the strength. A grade 0 means we feel no pulse. They may be very well alive and absolutely have a pulse, but we just can't feel the pulse in that pulse location. A grade +1 means the pulse is weaker than normal. A grade +2 pulse is normal and has a strong pulse that we would expect them to have as normal. A grade +3 means it's very strong and bounding, maybe too strong. A word of caution though, some electronic medical records have a grade scale that goes from 0 to 4, making a +2 to +3 their normal ranges, and then a +4 be bounding. So make sure you know what you are charting based on your system at your job. All right, let's move on to respirations. When we look at respirations, there are some terms you need to know about, which will be discussed later in block 1 as well. The first is ventilation. Ventilation is the process of air going in and out of the lungs. Inspiration, air in, and expiration, air out. Respiration is not the same thing as ventilation. Respiration is the gas exchange between the body and the external environment. So when we're counting respirations, we're actually counting ventilation cycle, inhalation, exhalation, one cycle, one breath. Breathing is an involuntary body action. We don't control it, our body does. Our body will adjust our respiratory rate based on many things, like if we're sleeping or running, in response to pain, some medications, emotional stress like anxiety, and respiratory diseases. Whatever our body needs to do to make sure our cells are getting enough oxygen, it's going to do. If our body senses something isn't right with our oxygen in our blood and tissues, or if it senses too much carbon dioxide from our chemoreceptors, it will activate the respiratory centers in the medulla and pons in our brain and will change how fast or slow or how shallow or deep we're breathing. Increases in carbon dioxide is the most powerful respiratory stimulant in our body, and unless we have pulmonary diseases that affect our ability to breathe out carbon dioxide, we will change our breathing very quickly when our carbon dioxide increases and we won't even know it's happening. There are several terms in regard to respiratory rates and breathing. If we're breathing slower than 12 breaths per minute, that's called bradypnea. If we're breathing faster than 20, it's called tachypnea. We have tachypnea with any increases to our metabolic rate. So exercise and fever will increase our respiratory rate. Breathing from 12 to 20 per minute is called eupnea. We don't ever use that term. And if someone isn't breathing at all, meaning 0 respirations, that's called apnea. In addition to these, if someone's having difficult or labored breathing, we call this dyspnea. And if someone is having difficulty breathing while laying flat, we call this orthopnea. Now let's move into the hardest vital sign to measure, and that's blood pressure. So blood pressure is actually the force of the blood in our arteries pushing against the sides of our arterial walls. The blood leaves the heart via the left ventricle and pushes the blood out of the aorta and exerts pressure on the arterial walls. Because the hearts contract systole and relax diastole, we will have highs and lows in the pressures of the arteries. These are called systolic blood pressure, or the highest pressure in the artery, and diastolic blood pressure, or the lowest pressure in the artery. The difference between these two numbers is called the pulse pressure, and it's an important diagnostic tool for diseases you're going to learn about in higher blocks. Regulation of blood pressure is very complex. There are a lot of things that regulate blood pressure. First, we have short-term regulation, which usually involves nerves and humeral meaning body fluids. For nerves, our blood pressure is affected by our sympathetic and parasympathetic nervous systems. That same thing that's going to make the heart beat faster and stronger, or slower and not as strong. Remember the fight or flight we just talked about in the pulse. Okay, the pulse and the blood pressure are affected the exact same way. The amount of fluid in our blood, or the humeral factor, will affect how much stretch is placed on the heart muscle. The more stretch on the heart muscle, meaning the more fluid in the heart itself, the harder it's going to constrict, which means the blood will be pushed out of the heart harder, so higher systolic pressure. If our body has too much fluid or not enough, both cases, it will signal the renin-angiotensin-aldosterone system from the kidneys to regulate how much fluid should be in the bloodstream. These sentences together, everything I just said, describes the basics of cardiac output, which we're going to discuss later in the semester. Long-term regulation and that short-term we just talked about are going to be fluid regulated by that renin-angiotensin-aldosterone system from the kidneys. Just like the pulse, our blood pressure is affected by many things, and often the same exact things that affect our pulse. Pulse and blood pressure often go hand in hand, so if the pulse is affected by something, the blood pressure may be affected as well. In addition to the things that I discussed in pulse, the race of a person can affect blood pressure. Certain races are genetically predisposed to issues with their heart and kidneys, which both affect blood pressure. Food intake, especially high sodium foods, will alter blood pressure, and blood pressures may increase after eating. Weight can also affect blood pressure. People with higher weights often have higher blood pressure. So someone who has a blood pressure less than 120 over less than 80 is called normotensive, or they have normotension. If their blood pressure is higher than that, we call it hypertension. However, the American Heart Association has different levels of hypertension, so it's not as simple as that. If the person's blood pressure is less than 90 over less than 60, this is called hypotension, or they are hypotensive. Hypotension can cause some disease processes like dehydration. It can be caused by effects of medications or even fevers. Basically, whatever is causing the body not to be able to maintain or return the blood pressure back to normal. As you move through the blocks, you're going to learn about diseases that can cause hypotension, and there are a lot of them. Orthostatic hypotension is a common form of hypotension. It's when someone has a normal blood pressure when they're sitting or laying, but as soon as they go vertical, like standing, their blood pressure drops significantly to less than 90 over less than 60. Orthostatic hypotension normally occurs from dehydration, blood loss, certain neurocardiac or endocrine issues, and the side effects of medications. The person may get dizzy, lightheaded, confused, and weak, and they may actually pass out when they stand. To assess blood pressure, you need a stethoscope and a sphygmomanometer, or a blood pressure cuff. You can also use the cuff and a Doppler to get a Doppler signal instead of listening with a stethoscope. The most commonly used is the blood pressure machine. However, there are times you can't use a blood pressure machine. So it's important that nurses are able to auscultate blood pressures, meaning use your ears and actually listen and get a blood pressure. Auscultating blood pressure takes skill. It can be easy for some people and hard for others. What we're doing is pumping the blood pressure cuff up over their normal blood pressure. We normally pump the cuff 20 to 30 millimeters of mercury higher than their stated known blood pressure. We call this a one-step blood pressure. If we don't know what their blood pressure is and they can't tell us, we need to do a two-step blood pressure. For a two-step blood pressure, we're going to palpate their brachial artery while we pump the cuff up. When we stop feeling the pulse in our fingers from feeling that brachial artery, we look at the cuff reading. That number is going to be what we pump 20 to 30 millimeters of mercury higher than. So that is like the first step of the two-step process. But if they can tell you, hey, my blood pressure is normally 120 over 80, we're going to pump it 20 to 30 millimeters of mercury above that 120, and that's a one-step blood pressure. When we actually do the auscultation, we're going to pump the cuff up 20 to 30 millimeters of mercury above their stated blood pressure while placing our stethoscope over the brachial artery. We're going to slowly deflate the cuff, listening for our cuff sounds. The first sound we hear, the first one, is our systolic blood pressure. So you need to hear it and watch at the same time. The last sound we hear is the diastolic blood pressure. So first sound, last sound. The sounds are going to change as the blood pressure slowly returns to the arm, and that's totally normal. They're going to change. That's what it's supposed to do. But we are listening for that first sound and that last sound. When we do blood pressures, we want to make sure the patient's arm is relaxed, their legs are uncrossed, and we're using the correct size cuff for the patient's arm. If we don't do these things, we're going to get inaccurate readings, which could affect how we treat the patient. When we assess the pulse ox of our patient, we're really doing a non-invasive measurement of their peripheral arterial oxyhemoglobin saturation, or their SpO2, of their arterial blood. The machine gives us a result, which is expressed as a percentage between the actual oxygen content of the hemoglobin and the potential maximum oxygen carrying capacity of that hemoglobin. So it's saying, hey, in your hemoglobins, if you can fill 100% of your hemoglobins with oxygen, you're only filling 98% of them. That's that percentage. The normal range for a pulse oximeter reading is 90 to 100%, depending on the health status of the patient. Health problems may cause different numbers, and any disease processes they have may alter what we consider normal for them. But anything less than 90% is going to be considered low in everyone, and it indicates that oxygenation to the tissues may be inadequate, and we should be investigating that potential hypoxia. Hypoxemia is low oxygen levels in the blood, and hypoxia is low oxygen levels in the tissues and cells. Those terms get used interchangeably, but they are actually two totally different terms. Depending on where you work, a reading less than 95% may be considered abnormal. So you really need to know what the normals are for your patient population you're caring for. Pulse oximetry is useful for monitoring patients receiving oxygen, but we do pulse oximetry on basically everyone we do vital signs on. To make sure we have an adequate pulse oximetry reading, we need to make sure their hands are warm. Cold hands have limited blood flow, and that can cause artificially low readings. Anything that can limit the blood flow to the fingers will affect the readings, honestly. Moving around will make it harder for the meter to measure the oxygen. Dark colored nail polishes may affect readings, as well as artificial nails. There is some data out there with certain pulse oximetry machines that the color of a person's skin may affect the readings as well. People with extremely low oxygen saturations are not going to have accurate readings after certain points. If the meter is saying they're less than 80%, we know it's low, but we're not going to have an accurate reading of what low truly is if we get less than 80%. And this is the end of vital signs.